E dando continuidade, é nossa satisfação agora convidar o professor Pierre Singer. Ele é um médico formado na França, pela Faculdade de Medicina de Estrasburgo, mas ele hoje está como diretor do Departamento de Terapia Intensiva do Rabin Medical Center em Israel. Além disso, ele é chefe do Instituto de Pesquisa em Nutrição no mesmo Centro Médico Rabin, chefe do Comitê de Nutrição Clalit, e ele é professor adjunto clínico de anestesia e cuidados intensivos na Faculdade de Medicina Sackler da Universidade de Tel Aviv. Por favor, Dr. Pierre vai nos brindar com sua palestra sobre metabolismo precoce e exercício na UTI.
Thank you very much, Dan, for the invitation and the very kind introduction. The topic you choose to give to me, thank you, is very challenging. It's a new topic actually, because the concept of doing exercise in CICU is quite new. It's maybe 15 years, and the data that is accumulating now is also new, so it's an interesting topic because it's going into the same direction of the concept which is called anabolic resistance. It is inspired by different issues that have been demonstrated in the literature, like for instance better insulin sensitivity when patients who are diabetic are doing more exercise. So the facts have been very well shown by Evans and Diogo. People in the ICU are losing a lot of muscle mass, and this is really very impressive. You can see that they can lose hundreds of grams of muscle, and we know that when these patients are coming out of the ICU, they have a loss of muscle mass that is very impressive. They are not able to stand on their feet. They are leaving the ICU in their bed, and you can also see that it can reach kilogram of muscles at the end of the hospitalization. This graph is inspired by a discussion we had with Gianni Biolo, who has been done a lot of studies on muscle metabolism in bedridden people on sake of the European Aeronautic Society and the NASA, because one of the main problems of astronauts is a lack of gravity, and they are lying in a bed, and people who are lying in a bed are like astronauts. They have lost their gravity, and this is losing a lot of muscle. Gianni demonstrated that actually the bedridden situation, bed rest, is definitively a stressful condition, increasing C-reactive protein, increasing pro-inflammatory cytokines. You put healthy volunteer in a bed for a while, 2 weeks, 3 weeks, this is a pro-inflammatory status. No disease, no IT intensive care, just putting them in a bed. So when you have these long-term patients that are staying 1 week, 2 weeks, 2 months sometimes in a bed, of course they are losing muscle, but they are also associated with inflammation. This muscle inactivity is creating reactive oxygen species, and there is an association also of ubiquitin proteasome system as well as autophagy, and this is leading to a muscle atrophy. Now we have a balance between catabolism and anabolism, and you can see that in this catabolism process we have a stimulation by calcium and capsaicin, and a stimulation of the ubiquitinization, which is fixed on actin and myosin fibrin of the muscle, stimulated by NF-kappa B and the inflammation. And this process is going through a proteasome. The ubiquitin is released, and this protein debris are going into an autophagosome, and this is autophagy. So as you can see that these processes of ubiquitinization and autophagy are linked one to the other. Now, when you look at this interesting study also from Gianni Biolo, and I will quote him quite a lot because he did a lot of studies for the last 20 years regarding this issue. It's together with Robert Wolf, we will give the Cuthbertson lecture at the ESPEN, the next ESPEN, on his huge work on metabolism in critically ill patients. You can see actually that the protein synthesis is, and this is expressed in the fractional protein synthesis rate, is increased in stress. People think that there is only catabolism that it increased, but the body is reacting with an increase in synthesis too. So you have an unbalanced process with more catabolism than synthesis, but both processes are increased. And people are paying a price that is very high, even showed it very nicely. This is people who are leaving the ICU while they are frail, as defined by the different definitions. And you can see that 6 months and 12 months after leaving the ICU, there is a significant decrease in quality of life. This has also been described more in the world of ICU by the group of Grete Vandenberg, because these are people who are leaving the ICU alive and 1 year mortality after. And you can see that those who are suffering from the acquired weakness after ICU are dying more than those who have not. And it can be defined by different scores. The MRC medical record computerizes better to define who are the patients who will survive more according to this score. And actually, when a patient is leaving your ICU, you should make this score. It's very important to know what will go on. But also it will test how much you have been good in preventing this frailty. Of course, not all the patients are the same. And we are keeping saying that all the time. People are speaking about ICU population. But in the ICU population, you can have a healthy young individual. You can have a young individual but with premorbid status, or you have an elderly patient with a chronic renal failure and a diabetes, and these are the future of these patients are very different. As we cannot say that all the ICU patients are the same, we cannot say either that the muscles are the same. You have different parts in the muscles. You have nerves, you have muscles, but you have also fibers that are very different, each from the other. And you can see here the type 1, type 2A, type 2B, type 2D, and you can see that according to this classification, the force production can be weak, intermediate, or strong. The shortening velocity can be slow or fast. The fatigue resistance can be good, or the muscle can be very much fatigable. So when you are targeting to a muscle, you really don't know which kind of fiber you are targeting to. So it's much more complex. And I'm sorry if I'm going more and more in complexity in this field, because of course you say exercise, but which kind of exercise to which target of which muscle and which protein, this is really very complex. And you can see that when you do a contraction, you are stimulating AMPK and CRT1, and this is actually producing a lot of stimulation for glucose metabolism and a better sensitivity. The mitochondria is also stimulated, and you have a switch, a shift between the fast to slow fiber phenotype and a better resistance to fatigue and a better muscle performance improvement. So this stimulation of the muscle by exercise or by contraction is helping the muscle to get stronger. Now, paradoxically, we were speaking about autophagy, and autophagy is known to be inhibited by nutrition. But when you do a contraction to a muscle, this is of course using ATP, and your ratio between AMP and ATP is increasing, and this is inducing more AMPK again, and this actually will improve the processes of autophagy. So in one hand, if you are not giving too much nutrition, you will increase autophagy. But if you are giving more exercise to your patient, you will also increase autophagy. So this is very favorable for the cells, mainly as the acute event, helping to prevent what you were speaking about, which is PICS. Because PICS is maybe also a post-ICU syndrome, but it's also a chronic inflammatory process. And this chronic inflammatory process is induced by debris of cells that have been injured, and the body is not able to clean them. And these debris are creating a chronic inflammation. And autophagy is able, by this autophagosome and the lysosome, to clean this. And when you give more exercise, you are also able to clean the body from these debris. So these are new concepts that we didn't know before, and we learn them more and more. I had some videos, but they are not working. We will pass them afterwards, because today I was asked to speak about exercise. And you have more and more papers that are coming out. This is a paper from a very good journal of intensive care medicine, and this study is looking to what is going on in the patients as far as the exercise strategy are concerned, and the duration and the number of sessions. Because we speak about exercise, but we have to define how much. It's like a drug. You have to know how long you are doing exercise to your patients. 20 minutes, 40 minutes, every day, twice a day, 3 times a day. It's like an antibiotic. And which kind of exercise you are doing. And you can see passive range of motion, active range of motion, electrical muscle stimulation. And you can see the duration in minutes that these people are doing. And this is actually affecting, you know that this will come back always, the MRC scores, the Medical Research Council scale, that is used to measure the power of force of the patients. And you can see that between the intervention and the standard care, there is no difference, but the patients are improving at the end of the study their quality of life and their anxiety score. This is at the limit of significance. This is a hospital-acquired syndrome of stress. You can see that this is a summary of many exercises that are used in the ICU. It can be passive exercise, it can be mobilizations in the bed, it can be sitting in a chair and doing ambulation, it can be cycle ergometry, it can be stimulation by electrodes. And these all studies have shown some significant differences, a decrease in length of mechanical ventilation in this study, a significantly higher return to independent function in this study, significantly increased 6-minute walk distance and quadriceps force and physical functioning, etc. We will go a little bit more in deep of these studies because they are interesting. But you have different tests. Not all of them are significant. And not everything is good in exercise. It's a problem because it's learning the system also. It's new. So you have to know which kind of exercise you can use. This is using neuromuscular stimulation. And you can see actually that between the two groups, the study group and the control group, they couldn't find any significant difference, but only in patients who were suffering from acquired weakness, ICU, there was a better improvement. This is a pilot of, again, electrical stimulation together with cycling. So you make the patient cycle in the bed, and you also put some electrodes, and you stimulate his quadriceps in addition to that. So this is a mixed process, and they were looking to the effects on sedation, delirium, and general outcome. And what you can see is really very impressive differences in the number of the people who are requiring rehabilitation, 86% versus 43%. Those who are going home is much more higher. No difference in mortality, no difference in the ICU stay, no difference in the length in the hospital. But when you look again to the different parameters, it's very impressive to see that you are able to improve the outcome of these patients. This is one of the pioneers of the exercise in the ICU. He's called Chris Burton. He did cycloergometria in around 70 patients, and you can see that in the control group the force is not improved, but in the study group yes improved. The 6-minute walk test is improved, and the quality of life difficulties to say that it is significantly improved, but it is according to the study. This is a study Evans showed us, also published in the Lancet, showing a return to the independent functional status after this hospital discharge, which is significant. This is also a very important concept. That is to say that it's difficult to find a significant improvement during the ICU. ICU stay is many times very short. 7 days, 5 days. You have people publishing 2 days. In 2 days you cannot reach anything. But in 5, 7 days, you have to look to the long term. You have to look to the hospital stay, and you have to look to the home stay and 6 months or 1 year function. So then you will maybe find a difference. Exercise is a stress for the patient. So you have to select your patients properly. It's not so easy. I will show you afterwards a study we did, and we had a lot of exclusion criteria, because patients who are suffering from heart problems or ischemic heart disease, you do them a test, an exercise test. Or those people who have a trauma and have problems with legs, those people who have a previous or CVA or problems of function, it's of course complicated. Now, another study that has been shown, just published I think 2 days ago, is a study from Laurent Brochard. I just wanted to say that the increase in oxygen consumption here is significant. It's around 25% increase in oxygen consumption. Here Laurent Brochard is looking to the appropriate ventilation to do to these patients, to not increase too much oxygen consumption, so that the patient will receive the ventilation they are requiring. And it seems to be that proportional ventilation is better than PSV. These are the differences between oxygen consumption before and after exercise. One of the most strong studies on exercise has been published by the Bet Israel in Boston, and they are doing exercise according to the ability of the patient to participate. And you have the level 0, no activity, the passive, the sitting stage, the standing stage, and the true mobilization. And it's incredible to show that when they are doing this in a large population, the ICU length of stay is decreased by 3 days, and the function of the patient is also significantly improved as the subdomain of locomotion transfer are concerned. The quality of life is not changed at the long term. I have to go a little bit faster, but you can see that the side effects of mobilization, because it's not easy to mobilize a patient who is connected to a ventilator and to a lines and sometimes to hemodialysis. You could see even patients with ECMO that are walking. So all these patients are complicated. So of course, would like to see if the patient is falling, if his endotracheal tube is dislodged, etc., etc. You can see that this is very small. So the conclusions of this study was it's possible to do a mobility according to the level. This is decreasing length of stays and improving lung function. You can see here a Brazilian study looking to a passive cycling, passive. and looking at the muscle strength and the duration of mechanical ventilation, you can see that there was no difference in the length of stay and the mechanical ventilation days, but there was an improvement in the MRC. Now we go to nutrition, because we have to speak about nutrition. What's going on about nutrition? There are some studies telling us that if you do exercise and you eat after you are receiving a feeding, your capacity to create a fractional synthesis rate of the muscle is improved. That is to say, you associate food and exercise, and you are able to build more muscle. It's very important. And it's again the concept of Gianni Biolo, comparing a rest situation, giving amino acids for 3 hours, and after exercise. And you can see the improvement in the protein synthesis according to stable isotopes. So this is basic science showing you that if you do amino acids together with exercise, you are able to create a stronger muscle. And of course, also, younger and older patients have not the same reaction. I will just finish with a study we ran in our unit. The concept has been given many years ago, so we put all this data together, and as I said, we had problems to recruit patients because of our exclusion criteria, but we finally succeeded, and this will be presented in an oral presentation in ESPEN. So I show you a little bit of the study, not all of the study, but we decided to do 3 groups. A conventional group receiving a regular physiotherapy together with balanced diet. A group with cycle ergometry and a balanced diet, and a group enriched in protein with same calories with a cycle ergometry of 20 minutes a day. And these are our patients cycling. You can make them cycle like that or like this. We have different devices. This is the demographic of the patient. We have younger patients at the Syrio-Lebanese. We have 6 patients. These are 22. Apache score so far, which is slightly higher in the 3rd group. And the energy expenditure that is, of course, in our unit measured of around 1,800, 1,900 kilocalories. The proteins that have been absorbed are not extra proteins. They are using different formulas. And we are limited in the amount of this protein according to the formulas. So this study was sponsored by Abbott. We had to use Abbott products. And this is an Abbott product which is much more enriched in protein. So you can see that we are reaching 1.1, 1.2 grams per kilo. The amount of calories that the patients were receiving were around 80% of the measured energy expenditure. You can see that these patients have an hypoalbuminemia. The RQ is okay. We didn't find a significant difference in the length of stay, length of ventilation, which was our main objective. It was not different. You can see that the days of ventilation were not different. Length of stay in the hospital was not different. The percentage of patients weaned was higher in the group 3, but it didn't reach a significance. And the number of pneumonia was lower in this group also. We are finalizing the data because some of the patients were going to rehabilitation, and we were able to follow their length of stay all together. And so we are collecting this data, and we are believing that maybe in the long term we will find maybe some significant difference. We were also looking to the fluid balance, which is also a very important parameter. I just would like to remind you, Diogo was showing this data, that a part of the results of this analysis was to find the fact that when you are giving more protein to a patient, your length of stay was increased. This is a little bit different, but there is a part of the paradoxical findings that you can see in nutrition, because you may improve survival, but you may increase also the length of stay or the length of ventilation. Why is that? Because you are paying by the length of stay the stay in the ICU. If not, the patient is dying and the stay is shorter. So if you are making a survivor, the survivor will stay longer. Not everything is very nice and all the parameters would decrease. So you have to look at some of the studies that have been published and are showing that there is sometimes an increase in length of stay and a decrease in mortality. So until a certain level of protein, the length of ventilation could be increased by additional protein. So this is also some of the interpretation that we can give. This group is pushing for a multimodal intervention associating nutrition, maybe anti-catabolic or anti-inflammatory therapies. Beta blockers are definitively one of the big drugs that we should use more. Exercise by different modes that we have to define, the intensity, the time that we will use, and therefore we cannot say today that giving more protein together with exercise is helping patients in the ICU. Of course, we will need better, larger studies, but of course we can say that this exercise is improving the level of function and the length of stay by goal-oriented activity. Thank you very much.